Good afternoon. So thanks for inviting me to do this, Chad, and thanks for the intro. It's nice to see some familiar faces. So I am one of the movement disorder specialists at UMass, as Chad mentioned. I think you heard from my colleague, Kara Smith, last week, and I had decided to talk about autonomic symptoms in Parkinson's today. This is by no means comprehensive. It's going to focus on a few of the more common autonomic symptoms we see in Parkinson's disease. I will go over, let me actually just minimize this for a second so that I can see the slides. 1 second, sorry. So I'm going to talk about the definition of autonomic nervous system. I will review some of the common autonomic symptoms in Parkinson's, and then review treatment and management options at the end. So if you're welcome to ask questions as I go along, but just know that I'll get to some of the treatment management questions at the end of the talk. And of course, I expect this to be about 20 minutes of talking for me, and then 20 to 30 minutes, and then we'll open it up to discussion and questions after that. So just to give you a little bit of an overview, and some of this will delve a little bit into the science of it, but I tried to keep it somewhat basic as well so that everyone can understand. So we talk about the autonomic symptoms, and that's actually controlled by the autonomic nervous system. So you might have heard about the central nervous system, which is the brain and the spinal cord, the peripheral nervous system, which are all the nerves that are throughout your body, and then the autonomic nervous system is kind of in both areas. There's parts of the autonomic system controlled by the brain, and then parts that are controlled in the periphery as well. So this is why it can be kind of invasive and affect all the organ systems. So there's two other terms that you might have heard in the past as well, called sympathetic and parasympathetic, and I'll go into that a little bit more, but those are the two main kind of controlling factors on the autonomic system, and they do that through nerves, and the sympathetic and parasympathetic systems control, again, all organ systems, and I'll show you like a diagram that might explain it a little bit better. So this regulates your heart rate, your blood pressure, your digestion, urination, sexual function, and kind of helps to regulate when these things need to go up and when they need to go down. So for example, the sympathetic system is our fight or flight system. So you might have heard of fight or flight. This is the system that goes into effect when there's an emergency, when we panic and we say, oh my God, I have to, well, the typical example they give is like you're in the woods and you have to run away from a bear or something like that. Then your fight or flight system comes into effect, and basically everything shuts down, like your digestive system shuts down, your urinary system shuts down, so that you can just focus on running away. And so how that happens is because of these nerves and the brain kind of controlling which system is which system is going up and which system is going down. But that does happen on a daily basis as well. So if you're sleeping, then your rest and digest system, which is your parasympathetic system, is more in effect. And so that's the time you're conserving energy. Again, your gut is slower during the nighttime when you're sleeping. It's not like all your blood flow is not really going into your gut during the rest and digest time, because obviously you don't want to have to be going to the bathroom overnight. But your blood pressures might be lower overnight as well. Your heart rate could be lower overnight just because your system is kind of down and you're trying to get rest. Whereas during the day, when you wake up, that sympathetic system drive kind of comes up again. So these two systems are constantly in this balance, going up and down, and your body is used to that and is used to kind of balancing the two systems out. I gave a little bit of, these are the kind of neurochemicals involved. So epinephrine and norepinephrine in the sympathetic system. So when it's time for fight or flight, your epinephrine levels go up. Whereas in the parasympathetic system, it's acetylcholine, in case you were interested in that. This again is not really to look at each individual line here, but just to give you an example This is the brain up top, the spinal cord, and showing that the sympathetic system over here, all the nerves and innervating all the different organ systems, and then the parasympathetic similarly innervating pretty much all the different organ systems. So hence why, depending on the balance, one might be more active than the other, and depending on the time of day and the activity you're trying to do. So this kind of brings us to, well, why is this relevant in Parkinson's? Well, in Parkinson's disease, that autonomic nervous system can actually be dysfunctional. So the reason is we think that alpha-synuclein, just like the abnormal protein in Parkinson's, deposits in various parts of the brain and the gut. It also deposits in the nerves as well, and in the autonomic nervous system. So again, a lot of this balance that I was talking about, kind of balancing the sympathetic and parasympathetic, can be quite dysfunctional in Parkinson's. So what happens? Well, some of the common features that we see, and we'll go into these in a little bit more detail. We see orthostatic hypotension is one of the most common manifestations of autonomic dysfunction in Parkinson's, and that is low blood pressure. And I'll go into that in more detail in a couple of slides. GI dysmotility, or your gastrointestinal motility, can be dysfunctional. And most commonly that can manifest as constipation because of the slow transit through the gut. And the gut is interesting because not only does it get input from the brain and from the nerves in the periphery, it also gets its own input. It has its own nerves in there too. And its own kind of neurochemicals in the gut. So that complicates it even a little bit more. There can also be dysfunction in stooling and having bowel movements. And then there can be some issues with contracting the muscle to have a bowel movement, where it might not contract when you want it to. So there's multiple different issues that can come up with the GI system. Sialorrhea is drooling. And so drooling occurs because of alpha-synuclein in the salivary glands. And what happens is that actually salivary secretion is reduced, but what happens is that there's difficulty in swallowing. And so if you're not swallowing at the rate that you should be, then you get pooling of that saliva and then drooling. Urinary symptoms is another common one, and this can be even more complex because there can be urinary symptoms from other medical issues. So some benign prostate hypertrophy, or BPH, is really common in men, and that can cause urinary symptoms in general. A lot of women who have had children and might have pelvic floor issues might also have urinary frequency, and so these could be, in addition to what Parkinson's can cause as well. So the most common issues in Parkinson's are nocturia, which is nighttime awakening to urinate, urinary urgency, and frequency. So let's talk a little bit more about orthostatic hypotension, which is one of the most common, if not the most common, autonomic symptom we see in Parkinson's. So by definition, it's a reduction in the systolic blood pressure, which is that top number of blood pressure, by 20 points, or in the bottom number, the diastolic, by 10 points within 3 minutes of standing. So this is why when we measure orthostatics, we ask to measure it while you're laying, and then while you're sitting, and then when you're standing. In the office, it might be sitting and then standing, and usually it should be at least a minute apart. And so when you see that 20 point difference, that's by definition orthostatic. However, some people do hover around that border. They might be like between 15 and 18 points dropping. Some people can tolerate that without issues, and others might have symptoms from that. So what are the symptoms? So let me go through this. I just saw the chat question. I'll come back to that in just a minute. So symptoms of orthostatic hypotension, there can definitely be fainting if it's more severe. There can be lightheadedness. There can be dizziness. Those are the most common. Sometimes there can be kind of like neck pain in this coat hanger distribution, which is like neck into shoulders. Often, again, when somebody changes position, and other things that come along with lightheadedness, like blurry vision, confusion, some thinking and memory issues if the blood pressure is low. This can be particularly exacerbated in the morning because blood pressure tends to be low to begin with. after meals, because a lot of your blood flow is directed to your gut and maybe away from your brain, so you might be a little bit more lightheaded, or in the heat because of dehydration. So Lauren asked, if you have drooling but no trouble swallowing, does that mean you're more likely to develop trouble swallowing? No, it's not. So drooling is not connected to what your swallowing function will be. It's just interesting because I think a lot of people think drooling happens because you're making too much saliva, but that's actually not what's happening. It's just that you're not swallowing at the rate that you should be. It doesn't even mean that you have a swallowing problem. It's that you're not swallowing as quickly as you should be. So I hope that, and it does not correlate with any future swallowing difficulties. Okay, so there's also what complicates the orthostatic hypotension picture a little bit more is that the medications that we prescribe for Parkinson's also can drop the blood pressure. So levodopa itself can decrease your blood pressure, and then dopamine agonists can decrease your blood pressure as well. Selegiline and the MAOB inhibitors can also lower. So anything that's dopaminergic can actually lower the blood pressure. And so this can complicate the picture. If the blood pressure is low or your neurologist thinks you have orthostatic hypotension, often we'll go over your Parkinson's meds. And the first step might be to decide, can we adjust any of those meds, meaning decrease any of the doses at a specific time to help. And before that, though, a lot of patients are on blood pressure medications to lower their blood pressure. So a first step, even before changing the Parkinson's meds, would be to screen the medication list and see, are there medications that control blood pressure? And can those be changed or decreased or taken off, discontinued altogether? And that's often a discussion with the primary care physician or cardiologist, whoever's prescribing the blood pressure medication. Excuse me. So often people that are hypertensive at baseline used to have really high blood pressure. Once they develop Parkinson's, can actually swing to the other side and develop low blood pressure. So they may not need those blood pressure medications anymore. So kind of moving a little bit, and as I said, I'll come back to treatment at the end, but moving on to one of the other symptoms we see, not as common of orthostatic hypotension, but definitely patients do bring this up, as sweating or lack of sweating, kind of heat intolerance, all in the same spectrum. And so sweating is mediated by the sympathetic nervous system as well. So again, if you think of that fight or flight, you start sweating when you're in that fight or flight mode. Your epinephrine levels, your adrenaline levels are really high, and there's a lot of sweat that comes along with that. And so there's receptors in the sweat glands that actually allow for that, for you to be able to sweat. And that's really important to manage your internal temperature as well. And the brain controls that as well to make sure that your internal temperature stays within a range. The issue is, again, that alpha-synuclein can affect the sweat glands, and this might affect your ability to sweat or your tolerance of heat. And so sometimes people feel really hot when it's not very hot outside, or really cold when it's hot. And so there can be this discrepancy of your sense of how hot or cold it is. Unfortunately, there's not really a whole lot that we can do with this one. We don't have great medications for the sweat issues that do come up, or the heat intolerance. Kind of other than using ice packs or cold packs or heat, depending on what you're feeling, there's not really medications that have been developed yet, at least, to help with this particular symptom. Urinary and bladder dysfunction, as well as sexual dysfunction. So these are also part of the autonomic symptoms we see in Parkinson's. So urine storage, so there's obviously the bladder where the urine is stored, and the bladder itself is made of muscle, and there's nerves that affect that muscle and tell it when to squeeze so that you can urinate, and tell it when to relax so that so when you're not urinating, and also tell it when to stay kind of closed even though it's full, because you're not ready yet to use the bathroom. And so it's complex, but to keep it simple, there is actually a center in the brain that controls this, called the pontine micturition center. And then there's also the nerves around the bladder that control this again. So again, your sympathetic and parasympathetic systems are important here too. And so you might hear the term neurogenic bladder. Often patients with Parkinson's have a neurogenic bladder, and that just means that there is dysfunction in that autonomic system affecting the bladder. There could be overactivity causing urinary urgency, frequency, nighttime urination, or there could be underactivity where there's incomplete bladder emptying. There could be retention of urine and overflow incontinence. So it really could be either or both, and that makes it complicated. Often, I know that personally, like I'll try to kind of gauge what the symptoms are and how bothersome they are. If they're becoming more complex or more active, I'll often work with a urologist to help manage the symptoms, which they can sometimes do with medications, and we'll come to that later as well. And then keeping in mind, we don't talk about this often, but sexual dysfunction as well is part of the autonomic issues that come up in Parkinson's. So there can be erectile or ejaculatory dysfunction. There can also be in women poor vaginal lubrication as well. And we'll come back to that. Let me just check this chat message. What are dangers of low blood pressure? So that's a really good question. Probably the most dangerous aspect of low blood pressure is that you could faint. And so if it's very low and you get very lightheaded, say you're getting up to use the bathroom in the middle of the night, and when you stand up, that blood pressure drops. You may not totally be aware of it because it's kind of the middle of the night and you're already tired and sleepy. You might feel a little lightheaded, but if it drops low enough, then you can fall and faint and lose consciousness. So that's definitely becomes a safety issue. There's even studies though that show that even if there's drops in blood pressure per the numbers like I talked about, and you don't feel symptoms, like you don't feel lightheaded, you don't feel dizzy, you're still at a higher risk of falls. So they found this in a study that even just with the numbers dropping, even if you don't have symptoms, it's worth keeping an eye on it and keeping an eye on safety because you're at a higher risk of falling. There's also been studies done looking at orthostatic hypotension affecting cognition in Parkinson's. And when blood pressure is low, cognition is actually affected. So it is hard to think, it's hard to coordinate, it's hard to, and that might make it hard to move. So if you're trying to move, you're trying to walk, and you can't think clearly, you're foggy, that could be a result of the low blood pressure. So those are some of the more dangerous things that could come up. In terms of GI dysmotility, so the GI system, again, it's modulated by these two systems, the parasympathetic and sympathetic. And the GI system kind of is its own environment as well. So the upper GI and the lower GI both get input from the brain and the local nerves, and then they have their own set of nerves as well. So it complicates it a bit more. The most common symptoms we see, so dysphagia or difficulty swallowing, regurgitation, satiety, which is a sense of fullness. Some people feel early fullness, so they eat just a very little bit and they get the sense of feeling very full. Nausea, bloating, postprandial or after eating, they can feel vomiting or nausea. And then constipation, which is probably the most common that we see. So this, again, kind of a more scientific diagram, but just to give you a sense of what it looks like. This is your GI system looking at your the tract, the esophagus, which is like where you swallow up here, going into your stomach, and then your small intestine, your large intestine, or your colon. And it shows the innervation. This is your spinal cord, and it shows like from the spinal cord, these nerves and these plexuses of nerves that are innervating everywhere throughout your gut, basically, all the areas. And then this is the gut itself, and just to show you kind of like how complex it is, this is the gut mucosa they're showing here, and muscle, and then there's all these different synapses or areas where neurochemicals come out. And that all depends on, again, what you're doing. Are you eating right now? Or you're not eating right now? Are you sleeping? Are you ready to run a race? These things will change depending on the environment and what your body needs to be doing. And it's just showing like this is that gut nervous system. These are the nerves coming from higher up. This is coming from your brain. So this is like the input from the brain and output, going back and forth. There's messages coming from the gut to the brain and messages going from the brain to the gut. So definitely complex, but makes it really difficult as well to treat. So we're going to shift a little bit to treatment. Orthostatic hypotension first. And so generally, at least I know at my office, we try to check sitting and standing blood pressures on all our Parkinson's patients at every office visit. And hopefully if you can make sure your primary does it when you go to see them, that would be helpful. Often the physical therapist will do it and check sitting and standing, and just gives us a sense of whether you're dropping or not. Because if you only check it sitting, it might look like your blood pressure is perfect all the time. However, if it drops when you stand up, that's when we're concerned. We usually, if somebody has orthostatic hypotension, we recommend increasing hydration, 60 to 80 ounces a day, which is a lot, but we try to have patients kind of slowly, gradually increase how much they take in. As I mentioned, if they're on an antihypertensive or a blood pressure medication, we reevaluate the need for this along with other care team members, like the primary care or cardiologist. We may consider changing the timing of the antihypertensive if they really need it, because it might be that early in the morning your blood pressure is low, but late morning, afternoon, it might be high. And so sometimes just changing the timing can be helpful. Compression stockings. And so I'm a big proponent of wearing compression stockings. That can be really helpful. It actually does raise that systolic blood pressure by 5 to 10 points just by wearing stockings. And so there's medical grade stockings, but there are also just regular kind of athletic type stockings too that go from ankle to knee and might be easier to wear and can make that difference during the day. When somebody has more severe symptoms and these things are not enough, we might encourage them to have an abdominal binder. It's kind of like a back brace, or might function the same way. It kind of squeezes the gut, and so the blood flow from the gut goes up into the brain and can help with that blood pressure. And then depending on cardiac history, if there's no contraindications, then we might say, okay, add some salt to your diet. There are physical maneuvers that can be done, like in the moment if you're feeling lightheaded or dizzy, crossing the legs, kind of putting one leg up. If you're able to squat by holding something, squatting would be useful. Anything to kind of push blood from the legs up into the head. Those are the maneuvers. I think crossing legs is fairly easy, but again, any of these I would recommend somebody like hold on to something and make sure that you have good balance before kind of going straight into this. Of course, if you can lay down somewhere, that will bring it up too, sitting or laying down. What are the medications we use for orthostatic hypotension? So you might have heard of some of these. Midodrine, which is a vasoconstrictor, meaning that it squeezes the blood vessels, and so it can increase your blood pressure that way. Fludrocortisone expands volume by reducing salt loss, so you get more volume of blood and therefore increase in blood pressure. Droxidopa or Northera, we talked about norepinephrine, so this is actually a norepinephrine prodrug, so it results in more norepinephrine, and that increases blood pressure. And then protostigmine, which is one that we use in neurology often for other medical issues. It's one that is an enzyme inhibitor but can help with some of the autonomic symptoms. The first three, midodrine, fludrocortisone, or droxidopa, can actually cause supine hypertension, which is high blood pressure when laying down. So we usually dose those in the morning into the early afternoon, with the latest dose at 4 o'clock. You should not be taking those medications past 4 or 5 o'clock, because when you lie down, the blood pressure might be too high. For urinary symptoms, as I mentioned, this can be kind of complex. Often if you see a urologist, they might be doing some evaluations or urodynamic evaluations to look for, what exactly is the problem. If it's a pelvic floor issue, they might send you to therapy for pelvic floor training. There are medications the ones that I recommend usually are solifenacin or trospium, because they tend not to affect cognition or memory, which some of the other ones like oxybutynin might affect memory. So we try to stay away from those. But sometimes I also just defer to the urologist to talk about medications. Catheterization, I mean, I don't usually recommend this, but and I would say it's less common in our Parkinson's patients, but sometimes it can be an option. Botulinum toxin injections or Botox injections can be used to relax the muscle if that's the issue. Again, that would be done by the urologist if they think that was necessary. And then sacral neuromodulation. I haven't had any patients who've had this, but this is like placement of a neuromodulator that might be stimulating the bladder when needed. More invasive procedure, but another option. For the GI dysfunction, so for constipation, we often talk about increasing physical activity and exercising, like through programs like DopaFit, increasing hydration and fiber, using osmotic and stimulant laxatives. Sometimes we'll say like Miralax is one that we often recommend. Rectal stimulants, I don't recommend these often, but some patients find them useful. Biofeedback, again, that's not something that I do, but there might be GI specialists that do use that type of feedback. Fecal incontinence is something we see more rarely. So I don't, again, if that is coming up and we think it's related to the Parkinson's, we often defer to the GI specialists on that. They might use specific medications. They might have other options that they can do for that kind of incontinence. Sexual dysfunction. So again, this is complex because it does require differentiating between a primary sexual dysfunction, a secondary from Parkinson's, or tertiary. So if there's other factors involved, then they might, it depends on where this is coming from. But what's most important is to bring it up with your neurologist. I think we also shy away from bringing up this issue, and I think it's really important because it can obviously affect your quality of life. Medication options do exist for erectile dysfunction. There's not really a whole lot of options, and there's not much for women either. So, but it might be helpful to at least talk about it. And that's kind of the short overview on symptoms. Thank you. This is Amira, my 6-month-old. And let me go back to the gallery here. So if anyone has questions, I'm happy to answer. Sure, somebody is raising their hand. I don't know if Chad,
Dr.
There you go, right.
Would a sweet tooth have anything to do with Parkinson's? Because I'm really go after sweets a lot, more than I used to.
That's a really good question. Not that I've heard of. I know it can affect definitely affect your sense of smell, can affect your sense of taste in that way, but I don't think it, I haven't heard of it really affecting you in terms of like what kind of foods you are attracted to.
Okay, thank you.
Elmar? This is David. Can you hear me? Elmar?
Yes, David, go ahead.
Yep.
Yeah, I wondered about the eyes, particularly dry eye.
Yeah. I'm trying to. So dry eyes definitely comes up. Actually, I think that Michael J. Fox Foundation had a nice webinar on all the kind of different eye-related symptoms that can come up. Many of which, like, we don't know very well the physiology of why it's happening. But, you know, that being said, we know that the eyes too are innervated by the parasympathetic and sympathetic. So there's the systems that can control you tearing or not tearing, and then and so it can definitely affect how lubricated your eye is. But that being said, dry eye is really common in the general population, so I don't know that that's particular to Parkinson's. But yeah, it's just very common, and so usually ophthalmologists can prescribe or recommend over-the-counter treatment options for dry eye.
Good, thank you.
Dr. Deb, a question from the chat. What kind of heart rhythm problems can occur due to PD or meds?
So good question. The meds that can cause heart rhythm issues, I would say, are usually the antipsychotics. And so if there's a complication of hallucinations or psychosis, and you're on a medication like Seroquel, quetiapine, or Nuplazid, some of these can prolong a specific interval in the heart rate called the QT interval. So often we'll make sure that you have a baseline EKG, make sure that it looks okay. It doesn't, I would say that if you have a normal EKG, we don't worry too much about it. But if you have an already prolonged QT, then we might have to keep a close eye on it, or we may need to think about whether that medication would be appropriate. Other than that, I can't really think of other heart, like arrhythmia type problems related to Parkinson's or the medication.
Okay, and then there's a question about incontinence. So I sometimes, excuse me, pass urine, although I do not have the sensation of wanting to go. Is this because my bladder is overflowing?
Is this because right, so this, that's kind of typical of neurogenic bladder, where you may not feel the sensation because the nerves there are probably affected. I don't know though if it's overflowing or not. That's not something I'll be able to tell just from your symptom. That's where the urologist would have to kind of do that urodynamic study. What they do is they look at how much urine is in the bladder, and then they might wait for you to pass the urine and then see how much is left in the bladder. So they'll be able to tell whether it's an overflow issue or whether it's an issue of not being able to empty completely. So there's different issues that could come up. It's hard to say just based on the symptom. I see the one is autonomic system dysfunction like ALS. What stage of Parkinson's does it fall under? No, so autonomic dysfunction is not ALS. ALS is a different disease altogether. The autonomic system is a system of nerves that everybody has. It's just that the function can be off in Parkinson's and in some other neurologic diseases like MS, they have a lot of autonomic symptoms as well. But it is not ALS. What stage of Parkinson's does it fall under? So it's not under a particular stage of Parkinson's. Some people have autonomic symptoms from very early on in the disease course, like orthostatic hypotension. Others develop it in the middle. Some people have it much later, and everyone has a different constellation of symptoms. Because I'm sure, as you've heard, one person with Parkinson's is one person with Parkinson's. So it really varies person to person, and so a particular stage. Would most of the symptoms with MSA be the same, but at a shorter time frame? Good question. MSA is multiple systems atrophy, which is on the spectrum of Parkinson's. It's another type of Parkinsonism where you can have severe autonomic symptoms. So someone might have very severe orthostatic hypotension that's not responding to the medications, that's affecting walking and balance. And could progress more quickly. So yes, it could be if you have many autonomic symptoms and they're severe or getting worse very quickly, we often think about MSA as a potential diagnosis. And that's something you would have to discuss with your neurologist. From Randy, my vision is often blurry, and when I get tired, I see double. I have cataracts in addition to convergence insufficiency. I do eye exercises for the latter. Do you have any suggestions? No, the blurry vision problem is one that many people have, and like your example, many people have other primary kind of issues with their eyes that may or may not be related to Parkinson's. Many people have cataracts or other issues with their vision. So I think eye exercises are what you should be doing. I don't have any other kind of additional recommendations. There's some thought that vision might be better when your dopaminergic levels are high. So like when you're at peak dose from your medications, just like everything else might feel better, your vision might be a little bit more optimal at that time. So if you do plan on doing some reading, that's kind of the best time to do it, not when you're in an off state where it might be a little bit more blurry or harder to focus. What about anxiety? Experience lots of anxiety. I would describe it as a feeling like I'm shaking internally, even when I may not be tremoring. Really good point, actually. I didn't talk about anxiety. I probably should have put in a slide about anxiety and mood. So that's another very common symptom. I don't consider it under autonomic. I think it's a common non-motor symptom in Parkinson's. So anxiety is extremely common, even if you never had anxiety before. As after developing Parkinson's, you can develop anxiety. And so that can also range from how anxious somebody is. It might be over just major events, but then others will say there's even little things that shouldn't make me anxious that are now making me anxious. And also might depend on what's going on in the environment or any changes in your life. Coronavirus being out there and everybody being quarantine doesn't help anxiety at all. So the anxiety can definitely worsen tremor. And so often we'll talk to patients about, well, if there's worsening tremor, do we think it's worsening tremor because of Parkinson's or worsening because of anxiety? And if we think there's a large anxiety component, we might discuss anti-anxiety medications, antidepressants to help with the anxiety that might then in turn help the tremor.
Dr. Deb, we have a hand raised by Laura.
Okay. Go ahead.
Laura, you want to go ahead?
Yeah, can you hear me?
Yes.
Okay. I was curious about the seborrheic dermatitis as a non-movement problem that exists.
Yeah, so seborrheic dermatitis is one of the skin findings that can happen in Parkinson's. Not everybody has it. Some people develop it more than others. And often we'll defer to the dermatologist to kind of recommend usually topical creams to help with it.
Okay, so it would be so the dermatitis. It doesn't ever go away though.
I think it's treatable. I mean, I think, if somebody's using the topical creams, it's treatable. Again, it kind of varies. Like some people have it really mildly and others have more severe. So it probably depends on where you are in that spectrum.
Right. I've tried the Nizoral, the shampoo, but it doesn't seem to work.
Quite help. And do you see a dermatologist?
No, I'll have to do that then.
Yeah, they're usually I honestly don't usually manage seborrheic dermatitis. I usually defer to the dermatologist because they'll have ideas of, what to use, and they can step up the grade of what you need depending.
Thank you.
And Dr. Jeb, I have a question. I get a lot of people, and I know you touched on it with sweating, excessive sweating in particular. Are there some things they can do outside of medicine to try to help with that? Especially, I think night sweats is the one that I hear about the most.
Yeah, we haven't found anything that's particularly helpful. I mean, I had tried medication like gabapentin with some patients, but we use it in menopausal women sometimes who also have like hot flashes and might have excessive sweating. So it might be similar mechanism, but I don't know. It doesn't work that well. Gabapentin has a lot of side effects, so I don't really use it anymore. And there's nothing great. I mean, even with the night sweats, there's not really anything that I've found to be helpful from a medication standpoint or not. Yeah, I know it's not a great answer. I don't have a good treatment option, but it is one that people have brought up to me as well.
Okay. What about some of the, they're not cooling mattresses, but the pads that might have a little fan underneath it that can cool your side of the bed? Because I think the biggest problem that people tend to have is not necessarily them sweating, but maybe their partner in bed with them, when they're excessively sweating, and then their partner having to kind of deal with some of the ramifications of that.
Yeah, no, that's a good point. I mean, I don't know about the cooling ones. I think that's fine to use. Like, okay. I'll say heating blankets for people that feel like excessively cold, and then sometimes ice packs and stuff. So yeah, I mean, I think any of those options are worth trying.
Okay, great. Thank you.
I see Isabella has her hand up there. Go ahead.
Oh, shit.
Oh, you're muted.
Yep, Isabel, you have to unmute yourself.
Okay, I just have a
There you
couple
go.
of questions for you.
Mhm.
Is skin sensitivity common with Parkinson's? My husband seems to be very sensitive, even to the touch. Sometimes it feels like you're really hurting him, even if you touch him.
Anywhere or a particular part of the body?
Just anywhere.
Not that I've really heard of. I mean, you can have, neuropathy or nerve damage in Parkinson's. That's often in the feet or the hands. And so people can be very sensitive in their feet or their lower kind of ankles for sure. But I haven't really heard of sensitivity kind of throughout the body.
Yes.
I guess presumably if there's other nerve endings that are affected, then that could be contributing.
And I feel, what are the side effects of gabapentin?
Oh, gabapentin can cause kind of sleepiness, dizziness, grogginess, things like that.
Okay, I have one more thing. Would you recommend probiotics for gut health?
So I don't recommend probiotics quite yet. There's a lot of studies going on the gut microbiome or the bacteria in the gut and how this is affecting Parkinson's. I think we don't quite have the information yet about the next steps, like what can we prescribe. I think right now the studies are looking at what are the bacteria that are in the gut and classifying that. And do those bacteria change when you're on medication and as you advance in stages of Parkinson's? And there's some indication that there are different groups of bacteria that are more dominant depending on what medications you're on and what stage of Parkinson's you're in. So I think we're still in that data collecting phase, and until we have more, it's hard to say. But some people do use probiotics just because it's a supplement, and some think that it does help their gut. So I am not opposed to it. I don't often, though, recommend it.
Okay, thank you.
And Dr. Deb, a question in the chat. I'll kind of broaden a little bit. Someone who is having orthostatic hypotension, and you're suggesting possibly, or their doctor may suggest that they take more salt, but they're told to be on a low sodium diet. So where do they go from there?
Yeah, so that's why I said you have to check with your primary or cardiologist, because if there's other heart conditions or heart issues, then I always say, like, do you have any other heart issues? Should you talk to your primary first before you just add salt? So salt may not be an option if you have other cardiac issues, in which case, back to the stockings and the hydration and potentially an abdominal binder, things like that. But salt may or may not be an option.
Okay.
And or medications that I mentioned to keep the blood pressure up, that might be necessary.
And there's a question about weight loss and related to Parkinson's.
So I don't think that there's typically weight loss. I think if swallowing is affected, that can obviously lead to weight loss if somebody's not eating. I've also heard that because of the loss of sense of smell, often patients' appetites decrease because they just can't taste as well. So I've heard that as well. I think those are some of the reasons why Parkinson's folks lose weight. We do encourage everyone to try to eat like well-balanced, healthy meals throughout the day. And if needed, also supplement with things like Ensure Boost if they're really dropping weight. And then also to talk to their primary about other reasons they could be losing weight. They should not be losing weight drastically just because of Parkinson's. So I often say, okay, let's work with the primary, make sure there's nothing else going on that could explain the weight loss.
Okay. And Lauren, you have your hand up?
Yeah. Hi.
Hello.
So I'm newly diagnosed in March, and I'm still trying to get a handle on the symptoms. And I think they're mainly non-motor function. So I'm the night sweat queen, But I also had burning mouth, and that seems to have decreased with the levodopa. Urinary problems. I mean, a lot of the symptoms could easily be associated with aging. So I'm struggling with trying to differentiate what I've got, what's causing it. I mean, does it really matter? I mean, the anxiety is managing the anxiety, whether that's due to Parkinson's. I've been on the anxious side of life most of the time, but it seems in the last year or two, it became more difficult to to get a grip on, and this has helped me understand what's going on. But how do you tell what's Parkinson's and what's not? And does it matter?
So that's not really your job, that's my job, right? So I don't think you need to figure out what is Parkinson's and what's not. You bring it up with your neurologist. You make a list and you bring up, hey, these are all the symptoms I'm having, what do you think? So the most common symptom that comes up with, I would say, is probably memory, because folks wonder, is this memory issue just because I'm getting older, or is it because of Parkinson's? And we have ways to try to navigate that. We have tests we can do, we have questions we can ask to try to figure out, is this just for now aging, or is this more, typical of what we see in Parkinson's? So I don't think that's something that you can easily figure out with all your symptoms.
I
think
keep forgetting to ask my neurologist about my memory.
That's why you have to write it down, right? You make a list, bring it into your appointment. In terms of which symptoms did you bring up? You said sweating, and then you said
Burning mouth.
Oh, burning mouth. Burning mouth is not one that I've really encountered very frequently. The other way to tell is if you're on medications, if your dopaminergic medications are helping, then it's more likely related to Parkinson's. If you're already on medication, it's not a reason to start necessarily medication, but I have had patients, once I started them on, say, levodopa, they came back and said, oh, like so many symptoms got better. And they may not have been ones that I would have guessed were related to Parkinson's, but they do feel better. So, sometimes that is an easier way to tell.
Thank you.
See you.
Oh.
There. Just say
Dr. Deb,
Yes.
listening to your talk, you have not mentioned at all DBS. And so are we to assume then that the symptoms that the autonomic system everything you've talked about today are not going to be improved by DBS, or not have an effect by DBS?
Oh, good question. I mean, I didn't go into DBS. I was just focusing on the autonomic symptoms. So the symptoms that I talked about today will not be helped by DBS. You are correct. So usually we say the non-motor symptoms, which autonomic fits under non-motor as well. DBS really only helps the motor symptoms, or anything that your levodopa helps, DBS should help.
Okay, thank you.
Another way to think about it, yeah. Coming back to, I will send Chad my slides, yep, and then he can send it out. That's not a problem. I'm kind of going backwards now. Obsessive compulsive behavior, is it common with levodopa? We do keep an eye on obsessive compulsive behavior. It's a lot more common with dopamine agonists like pramipexole, ropinirole, reticotine, those medications. Less common with carbidopa, levodopa. I take a probiotic recommended by my neurologist. Let's see, going back to orthostatic hypotension. Oh, that's the SALT question. Does weather or climate affect Parkinson's? I don't know if that's been studied really. I think some people might say they do feel better or worse depending on the barometric pressure. I think, though, that can also affect other things like arthritis. So it might be hard to say, is it really the Parkinson's affected or other issues? Does tinnitus play a part in Parkinson's? Tinnitus, I've had maybe a handful of patients with tinnitus and Parkinson's. I have not looked at the literature to see whether there are any studies on looking at tinnitus and Parkinson's. I haven't heard of it as a common part of Parkinson's, but I will say that I'm not sure. I would have to look into that.
I think Ginger has her hand raised.
Okay.
Yes. Can you hear me?
Yes.
Yeah.
Can you? Okay. I have a lot of rigidity. Is there anything I can do about that?
Yes.
I do take levodopa, but I don't. The doctor wanted me to increase it, but it makes me very nauseous. So
Sorry,
what happened here?
I picked up that you have a lot of rigidity. Your doctor has you on levodopa, but increasing it causes side effects. Is that right? You kind of cut off in between.
Yes. Yes.
Yeah, I mean, you should talk to your
Yes,
neurologist. Again, if
that's
you're
right.
a movement disorder specialist, they should be able to talk to you about other medication options. There are plenty. So I don't, obviously depending on what you've tried or not tried, there's a lot of dopaminergic medications that can be helpful with rigidity. Rigidity is one of the most common symptoms in Parkinson's. So, you'd have to talk to your neurologist or movement disorder specialist about that.
Okay. Thank you.
You're welcome. There's a question on managing pain with Parkinson's, and that is a tough question. I think there's also a lot we don't know about pain in Parkinson's. We do know that it can be one of the non-motor symptoms associated with Parkinson's, and it's often difficult to tell apart pain from other issues, just like arthritic issues, chronic low back pain issues, chronic rotator cuff issues, knees and hips that are already have arthritis can be difficult to tell, is there pain there because of rigidity from Parkinson's or because of that arthritis. That does require some examination of that, wherever that pain is, for us to get a feel for, could rigidity be playing a role? Or do we think this is more of an arthritis related issue, in which case it kind of depends on where the pain is. There's definitely pain medication options. And so again, it'll depend on, do we think this is nerve pain? Do we think this is some other type of pain? And we may need to work with the primary care doctor or a pain specialist, depending again on where this pain is coming from.
All right, I think we have time for one more question. If anyone has a burning desire that they want to ask and they've been holding back from. Michael, if you want to go ahead, you're going to have to unmute yourself.
Thanks, Chad. Nice to see you again. Quick question. Have you got a best guess as to when we resume in holding?
So as of right now, we are set for possible phase 3 on June 28th. That is the earliest time that they have us set for any group therapy practice. So stay tuned for the emails. If you haven't been yet, we do have our online workouts going on if you want to check those out as well. You can email me on the side and I will send everything over to you.
Okay, thank you.
Just wanted to ask Dr. Deb if she's heard anything about photolight therapy for Parkinson's.
I have not yet. So I have not heard about photolight therapy in Parkinson's. In the context of anything specifically?
Apparently it's from a single press release from the company. So let's take that a big sack of salt.
Maybe more to come.
But basically like a light box, that much like you said, that you'd sit in front of, and it might be helpful for non-motor issues. So I'm kind of curious about that.
Yeah, interesting. I'll keep my eye out. I haven't seen anything specifically.
Okay.
Yeah, I've seen research not specific to Parkinson's, but just specific to depression and things like that. So I'm assuming that more on Parkinson's will be soon to come.
It couldn't hide.
Didn't have the time to.
All right, well, I guess we will end it there. Dr. Deb, thank you very much.
Thank you, Chad, for having me. Thanks, everyone, and thanks for all your questions.
Thank you, Doctor.
Thank you.
Thanks. Hope you all stay well. Take care.
Bye-bye.
Bye.
So long.